Welcome back to Psych Escape. I hope you're doing great. If you've watched part 1, you're all set for today. If not, no worries, pause this video, head to the link in the description, and watch part 1 first. It'll give you the full context you need to follow along with this video. Now, let's jump right into part 2. How do people get OCD? Like most psychiatric conditions, research indicates that there is no single cause of OCD. Instead, most experts agree that OCD is likely caused by a combination of biological, psychological, and sociocultural factors. So, let's look over how do people get OCD. Changes in brain chemistry. Chemical messengers in the brain, known as neurotransmitters, transmit signals between brain cells, neurons. These signals are the biological basis in the brain for most of our experiences, like mood, sleep, memory, and learning. Some of these neurotransmitters are believed to play a large role in the development of OCD, hoarding, trichotillomania, compulsive skin picking, and other related disorders. Serotonin, for example, is a neurotransmitter that is important in the regulation of mood and impulse control. It also affects memory and learning processes. There seems to be a link between decreased levels of available serotonin in certain brain areas and the development of OCD, as well as other conditions such as depression and anxiety disorders. The antidepressant medications used to treat OCD work by raising the level of this messenger in the brain. Dopamine is an important neurotransmitter for the reward systems in the brain and has also been linked to OCD, and similarly, antipsychotic medications which affect dopamine can also sometimes be helpful to OCD. Another major neurotransmitter, glutamate, is now being investigated in its role in the development of OCD. Changes in brain activity. Researchers and clinicians are able to study the levels of brain activity, or metabolism, with advanced imaging techniques such as positron emission tomography, PET, single photon emission computed tomography, SPECT, and functional magnetic resonance imaging, fMRI. Such studies have consistently shown that individuals with OCD have increased levels of activity in 3 areas of the brain: the basal ganglia, prefrontal cortex, and cingulate gyrus. The caudate nucleus is a deep brain structure located in the basal ganglia. It is believed to act as a filter, screening messages that it receives from other areas of the brain. It also regulates habitual and repetitive behaviors, such as those observed in OCD and related disorders. Interestingly, the increased level of brain activity in this area normalizes in individuals after successful treatment of OCD, either with medications or cognitive behavior therapy. This demonstrates that changes in thinking that occur in therapy can alter physical functions in the brain. The prefrontal cortex is another structure implicated in OCD. It is involved in regulating appropriate social behavior. Diminished activity in this area can lead to poor impulse control, impaired judgment, and lack of remorse. Increased activity may therefore be related to increased worry about social and moral concerns, such as meticulousness, cleanliness, and fears of being inappropriate, all of which are amplified in OCD. The cingulate gyrus helps regulate emotion. It is also involved in predicting and avoiding negative outcomes and recognizing errors. In OCD, increased activity in this brain region may be related to the emotions triggered by obsessive thoughts and to feelings that one has made a mistake or not done something correctly. This area is well connected to the prefrontal cortex and basal ganglia via a number of brain circuits. Genetic factors in OCD. According to learning theorists, obsessions are conditioned stimuli. A relatively neutral stimulus becomes associated with fear or anxiety through a process of respondent conditioning by being paired with events that are noxious or anxiety-producing. Thus, previously neutral objects and thoughts become conditioned stimuli capable of provoking anxiety or discomfort. Compulsions are established in a different way. When a person discovers that a certain action reduces anxiety attached to an obsessional thought, he or she develops active avoidance strategies in the form of compulsions or ritualistic behaviors to control the anxiety. Gradually, because of their efficacy in reducing a painful secondary drive, anxiety, the avoidance strategies become fixed as learned patterns of compulsive behaviors. Before we move forward, make sure to like the video, subscribe to the channel, and hit the bell icon for more great content. Other possible causes. Number 1. Infection and OCD in children. Group A streptococcal infection, strep throat, has been linked to sudden OCD onset in some children, possibly due to an autoimmune response affecting the brain. No similar link exists for adult OCD. Number 2. Hormonal influence. Hormonal changes during premenstrual and postpartum periods can trigger or worsen OCD symptoms in some women. Number 3. Trauma and brain injury. Stress, traumatic events, and brain injuries like stroke may lead to the rapid development of OCD symptoms in certain cases. Now let's learn about psychological factors. Cognitive theory. Cognitive theory of OCD focuses on how people interpret their thoughts rather than their behaviors. It suggests that individuals with OCD misinterpret intrusive thoughts, giving them exaggerated importance, which leads to anxiety. While intrusive thoughts are common in most people, those with OCD see them as threats, causing distress and triggering compulsions or avoidance. For example, a person might avoid being alone with their child after having a harmful thought. Cognitive theorists have identified patterns of beliefs in OCD that contribute to these misinterpretations and compulsive reactions. Overinflated sense of responsibility, the belief that you are solely responsible for preventing harm to others. Exaggerated sense of threat, a tendency to overestimate the likelihood of danger. Overimportance of thoughts. Thoughts are very important and must be controlled. Thought-action fusion. Just having a thought increases the chances that it will come true and or that I will act on it. Perfectionism. Mistakes are unacceptable. Intolerance of uncertainty, a need for 100% certainty about a given situation. Behavioral theory. Unlike cognitive therapy, which looks at thoughts, behavior therapy focuses on the behaviors in OCD. According to behavior theory, OCD makes connections between certain situations and fear. Example, public bathroom equals anxiety. In order to reduce that fear, the person learns to avoid those situations or do rituals. A link is formed between the compulsion and feeling better. The more someone avoids or ritualizes in response to this fear, the stronger that link becomes. The stronger this connection, the more likely a person is to continue their avoidance or rituals because they don't have to confront or tolerate that distress. Their avoidance or compulsions become reinforced and the association may start to get triggered in other similar situations like bank machines or public handrails. In behavioral therapy, discussed in the treatment section, clients with OCD learn to break these links by confronting and tolerating their anxiety without avoidance or compulsions. This is done using exposure and response prevention, ERP, where clients confront a fearful situation and resist doing compulsions. The more a person is able to expose themselves to anxiety-provoking triggers without ritualizing, the easier it becomes. People learn that their fears may not come true and that they can tolerate the anxiety. Social and cultural factors. Research on OCD in different cultural groups suggests that there are no big differences across cultures, age, or between genders. Instead, OCD symptoms often seem related to the things we value most or that are particularly relevant in our lives. For example, obsessions about harming one's baby is common amongst new parents with OCD. Similarly, individuals raised in religious homes may develop obsessions that seem to contradict one's religious beliefs. Example, sexual thoughts about Jesus Christ. So what treatments are used for OCD? There is currently no cure for OCD, but effective treatment can help manage symptoms and restore normal functioning. Best practices recommend cognitive behavioral therapy, CBT, and antidepressants, with a combination of both being most effective for moderate to severe cases. It's crucial to seek OCD-specific treatment from a qualified CBT therapist, available in individual or group formats. While other forms of psychotherapy may help with general life issues, they are not effective for treating OCD. Supportive and family counseling may also provide additional benefits. Psychological treatment. CBT, cognitive behavior therapy, CBT, is widely considered the best psychological treatment available for OCD. Specifically, a form of CBT called exposure and response prevention, ERP, is the most commonly used therapy in major healthcare settings. This treatment is based on some known facts about anxiety. For better understanding, we have divided into 3 parts. Anxiety is a response to threat or danger. People with OCD interpret certain situations as dangerous and therefore anxiety gets triggered. When something is perceived as dangerous, the fight, flight, or freeze response kicks into gear. Anxiety is adaptive and helpful. We need it to survive. The fight, flight, freeze response is our body's way of staying safe. For example, if a car is racing towards us, anxiety helps us to get out of the way quickly. Or, if necessary, anxiety prepares us to fight off an attacker coming towards us. Anxiety is not dangerous. The anxiety itself is not a problem even though it may feel awful. How does exposure and response prevention (ERP) works? Got questions about OCD? Drop them in the comments, we'd love to help. If you enjoyed this video, hit the like button, it inspires us to create more videos like this. In ERP practice, a person will expose themselves to a situation that triggers anxiety and then prevent the usual OCD response, compulsion or avoidance. ERP is based on the idea that problematic anxiety is often a learned process and can therefore be unlearned. In ERP, people confront feared situations in a controlled and gradual fashion with the help of a therapist. The first step is to make a list of feared situations. The items on the list are organized in a hierarchy, from least anxiety-provoking to most anxiety-provoking. For example, someone with doubting obsessions might have a list that looks like this. Number 1. Leaving the house without checking the door, 40% anxiety. Number 2. Leaving work without checking office door, 70% anxiety. Number 3. Leaving house without touching knobs on stove, 90% anxiety. In exposure and response prevention (ERP) therapy, individuals gradually confront anxiety-triggering situations from easiest to hardest, following a structured hierarchy. The first session, typically guided by a therapist, lasts 45 minutes to 3 hours. Repeating the exposure regularly helps reinforce the idea that no harm will come from facing the fear, leading to habituation, where anxiety decreases over time. As confidence builds, more difficult situations are tackled. For those with obsessions but no visible compulsions, ERP is tailored, like writing feared thoughts repeatedly. In cases where direct exposure isn't possible, imaginal exposure is used, where the person vividly imagines anxiety-inducing scenarios. Over time, this process helps reduce symptoms and significantly improves their quality of life. What is self-directed ERP? For people with mild OCD, ERP can be done successfully without the help of a therapist. There are some excellent self-help books available to guide you through this process. If you're interested in book recommendations, just comment below and we'll suggest the best ones for you. Here is a big question: is ERP effective? Yes, research indicates that exposure and response prevention (ERP) can significantly reduce OCD symptoms by up to 80%, with many individuals maintaining these improvements over time. The effectiveness of ERP therapy depends on several factors, including the individual's motivation, the type of symptoms experienced, and the presence of other disorders, such as depression. Studies show that over 75% of patients see some level of improvement with ERP treatment, making it a highly beneficial approach for managing OCD. Cognitive strategies. In addition to exposure and response prevention, ERP, cognitive behavioral therapy, CBT, involves challenging unhelpful interpretations associated with OCD and promoting realistic thinking styles. Cognitive techniques help individuals identify problematic thought patterns that contribute to their OCD. When combining cognitive strategies with ERP, patients focus on their thoughts and feelings related to exposure situations, exploring what makes these situations distressing. For instance, individuals may overestimate dangers, such as believing they can easily contract hepatitis C from touching public doorknobs. Cognitive therapy techniques work to generate more realistic interpretations. Thought record. The thought record is a strategy used to challenge unhelpful, distorted thinking patterns. The goal of the thought record is to increase awareness of what we are thinking and then to examine the validity of our thoughts. Steps include rating moods, identifying thoughts that may relate to the negative or anxious feelings, and looking at evidence that does or does not support the thoughts. Using thought records can help reduce anxiety by challenging the beliefs involved in OCD. There are many other cognitive techniques that can be used in treating OCD. These include responsibility by continuum technique, probability estimation, double standard technique. How effective are cognitive strategies? Studies show that using cognitive techniques alone, without ERP, can help reduce OCD symptoms. However, experts generally agree that using both cognitive and ERP strategies is most effective. When used together, cognitive and behavior therapy tools work by learning new ways of thinking and behaving. Let's understand this with a diagram that illustrates the cycle of OCD from a cognitive behavioral therapy (CBT) perspective. This diagram typically shows how obsessive thoughts trigger anxiety, leading to compulsive behaviors aimed at reducing that anxiety. However, performing these compulsions ultimately reinforces the obsessions, creating a continuous cycle. Medications in the treatment of OCD. Medications, like cognitive behavioral therapy, can reduce the severity of OCD symptoms and may be an important part of any treatment plan. Although many people do well with psychological treatments alone, others may not feel ready for CBT or may prefer the relative ease of taking a medication. When illness symptoms are more severe, both types of treatment may be combined or provided sequentially. The first medication found to be effective for OCD was clomipramine, a drug used for depression, which increases levels of available serotonin in the brain. Since then, a number of antidepressants that work on the serotonin system have been found to be effective for OCD. The main class of medications is a large group of antidepressants called serotonin reuptake inhibitors, SRIs. These medications chemically block the absorption of serotonin by neurons, making more serotonin available to transmit messages in the brain. It is believed this change is associated with the improvement in OCD symptoms. Below we describe the three main subtypes of SRI medication: SSRIs, clomipramine, and SNRIs. Selective Serotonin Reuptake Inhibitors. SSRIs are a large class of antidepressants that specifically target the serotonin neurotransmitter system. They are commonly used as a first-line treatment for obsessive-compulsive disorder, OCD, due to their effectiveness and tolerability. The following medications fall under this category: fluoxetine, Prozac; fluvoxamine, Lavox; sertraline, Zoloft; paroxetine, Paxil; citalopram, Celexa; escitalopram, Cipralex Lexapro; clomipramine, anafranil. SRI clomipramine is the oldest and best studied SRI for OCD and depression and belongs to a separate class of antidepressants known as tricyclic antidepressants, TCAs. It is found to be equally effective, and in some studies slightly more effective, than SSRIs. About 80% of people taking it note improvement in OCD symptoms. However, it has a wider range of side effects that can make it more difficult to tolerate. As well, there are safety concerns for certain people. Because of this, clomipramine is often seen by treating physicians as a second choice after SSRIs. Serotonin and norepinephrine reuptake inhibitors, SNRIs. These are a newer group of SRIs that work on two neurotransmitter systems, serotonin and norepinephrine. These include venlafaxine, Effexor, duloxetine, Cymbalta, and desvenlafaxine, Pristic. Because of their similarity to SSRIs, they have a similar range of side effects. They are also believed to be effective for OCD, although they have not yet been as well studied as yet as the SSRIs. Because there is less evidence supporting their effectiveness in OCD, they are usually seen as a second-line option after SSRIs. Side effects. People are often concerned about side effects of such medications, and these are an important consideration when choosing the right medication for OCD. SSRIs. Because of their chemical similarities, these medications have similar side effects, with slight variations. In general, these effects subside with time and are quite mild. Most noted effects include stomach problems, such as constipation, diarrhea and/or nausea; insomnia or sedation; headaches; increased tendency to sweat; agitation; sexual side effects, e.g. loss of interest in sex. Clomipramine. Clomipramine has similar side effects as the SSRIs. Some patients may experience additional symptoms such as dry mouth, weight gain, blurred vision, dizziness with sitting. SNRIs. SNRIs are generally well tolerated. Similar to SSRIs, the most common side effects individuals experience include nausea, insomnia, dizziness. Important considerations with SRIs. While SRIs are highly effective in treating OCD, there are a number of points to consider in order to optimize their benefit. Firstly, it can take up to 6 to 10 weeks to notice improvement in OCD symptoms once the optimal dose is reached. Often, side effects can occur before any improvement is seen, which can be discouraging. It is important for individuals to be patient and continue the medication during this period in order to sustain its effects. When improvement does occur, it does so fairly gradually, with a reduction in intensity of obsessions and compulsions. A common reason for a poor or limited response to a medication is failure to take them for a sufficient period of time. In general, physicians recommend a trial of 3 months on an SRI before determining if it is effective for OCD. At this point, the individual and physician can assess clinical response and discuss appropriate next steps in treatment. Further, higher dosages of these medications are generally required than are typical for treating depression. Other medication options. Most doctors recommend that people with OCD start with one of the SSRIs. If the first medication option does not produce a response after a trial of 3 months, it is suggested to switch to another SSRI or clomipramine. The most common approach is for individuals to try at least 3 SRI medications described above before switching to other drug alternatives, which will be described below. If an individual experiences only a partial improvement on one medication alone, a secondary agent can be used. Addition of a second medication to a primary one is called augmentation. These options will be discussed below. Additional primary OCD medications. These are often considered as the third step in treating OCD after 2 to 3 trials of SRIs, though some individuals note benefit from these after limited response from earlier treatments. Generally, these medications all impact serotonin levels and pathways in the brain. Mirtazapine, Remeron, is an antidepressant that works on serotonin and norepinephrine levels in the brain. There is some evidence supporting its use for OCD, though additional studies are required. In general, Remeron is seen as less effective than SRIs in treating OCD. Once response is achieved. A common question relating to medications for OCD and other psychiatric conditions is how long medications need to be continued once there is an improvement in symptoms. It is generally recommended that individuals taking medication for OCD continue for at least 12 months and in some cases, 2 years or longer term. There is often concern expressed that these medications are addictive or that one can become dependent on them over time. Neither of these ideas are true. Even if taken long-term, these medications are safe and it is fairly common for individuals to stay on them long-term without such risk. Medications for augmentation. Addition of a secondary medication can be a very effective way to maximize response to an initial medication for OCD. These options are often no antidepressants and come from a variety of classes. Antipsychotic medications. Antipsychotics have the strongest evidence for benefit as add-on medications to SRIs for OCD symptoms. Older options, including haloperidol, Haldol, and Pimozide or UP, may provide specific benefit for people with OCD and concurrent tic disorders, such as Tourette's disorder. Newer antipsychotics, atypical antipsychotics, including risperidone, Risperdal, olanzapine, Zyprexa, and quetiapine, Seroquel, have been found to be effective for a broader range of people with OCD. A newer generation of antipsychotics, including an option called aripiprazole, shows some benefit, though further studies are needed. An important consideration with antipsychotics is the short-term and longer-term risk of side effects. This includes elevated triglyceride and cholesterol levels, weight gain, and diabetes, making some of these medications less suitable for people who are at risk for cardiovascular problems, such as heart attacks or strokes. Antipsychotics can also induce tardive dyskinesia, an involuntary movement disorder. However, this risk is less for newer antipsychotics. Sedation is also noted by individuals taking antipsychotics. All patients taking these medications require physician supervision and routine blood work and monitoring. Nevertheless, they are an important option to consider for most patients due to their effectiveness as augmenting agents in OCD. Benzodiazepines. These medications tend to alleviate anxiety and help with sleep, though it is unclear if they reduce the core symptoms of OCD. One of the best options in this class is clonazepam, Rivotril, a relatively longer-acting benzodiazepine which may alter the balance and availability of serotonin in the brain. Other medications in this category include lorgepam, Ativan, diazepam, Valium, oxazepam, Cerax, and temzepam, Restoril. Because these medications can cause sedation, they are hazardous to take when driving or operating machinery or during alcohol consumption. Further, they can impact short-term memory and learning. Hence, they can interfere with one's ability to engage with cognitive behavior therapy. Finally, there is a risk of dependence on such medications with regular use. Other augmenting agents. A number of mood-stabilizing drugs have been studied as add-on medications in OCD. Lithium is the best studied of these. Though this is very effective in bipolar disorder and as an augmenting agent for depression, it has little impact on reducing the intensity of obsessions and compulsions. Buspirone, Buspar, is an anxiety-alleviating medication that has complex effects on serotonin neurotransmission. Studies show some results in a subset of people with OCD, though there is a lack of consistent evidence and larger studies are required. Tryptophan is a naturally occurring amino acid found in certain foods and is related to serotonin production. It has been tried in conjunction with SSRIs with very limited effects on OCD. Although safe, it can cause considerable sedation. There is some research indicating that tryptophan might help if combined with lithium or an antihypertensive drug called pindolol, in addition to an SSRI. Newer medications. Medications that affect other chemicals in the brain continue to be studied as augmenting agents. For example, medications that affect glutamate, another chemical in the brain, have shown some promising results in small, initial studies. These include memantine, topiramate, and N-acetylcysteine. Larger studies are being designed to help better understand their potential role in the broader treatment of OCD symptoms. Herbal therapies. Herbal remedies have become more widely used in recent years as alternatives to conventional medications. However, there have been no studies to date exploring their effectiveness in treating OCD. Similar to other medications, such treatments pose potential risks of side effects and drug interactions. It is necessary to discuss these with a doctor. Treatments suggested for anxiety that may help with OCD include St. John's wort, ginkgo biloba, valerian root and evening primrose oil. Thanks for watching. Hope you enjoyed the video. Part 3 is coming soon. Check the description for Part 1. Stay tuned.